We're going to look at several joints: the jaw, the shoulder, the hip, the elbow. Perhaps the most complicated is the shoulder, and that's why I'm showcasing it here. It's composed of 3 different bones that are covered by muscle, ligaments, tendons, and other tissue that combine to make it a supportive structure. Here it is. Now, the range of motion of all joints is influenced by not just the shape of bone, but by ligaments, contact soft parts, tendons, hormones, and if we use it or not, we call it disuse. There's the scapula, clavicle, and the humerus. And if you remember the main bones and the parts of the bones, the acromion is the upper process, coracoid will be below. There's a glenohumeral. It's a glenoid fossa on the scapula, and the humerus is the arm bone, so that makes sense. The acromioclavicular AC joint involves the acromion and the clavicle, so those are good names. And the sternoclavicular, not much movement in that joint, and it involves the sternum and the clavicle. So you can see at first the words seem cumbersome, but then they start making a lot of sense. Temporomandibular, the TMJ, it's the only freely movable bone in the skull, besides the ossicles of the inner ear that are so tiny. There's a lateral ligament on the lateral surface. Let's take a look at this to the right. Doesn't look like much. It's attached to the zygomatic arch, cheekbone, down to the superior, inferior part of the mandible, but it's a major force in preventing dislocations. There's also stylomandibular that's attached to the styloid process of the temporal bone, coming down to the posterior mandible. Together, these help stabilize that joint, but permit some movement. We do have dislocations, such as a anterior, which is when the mandibles move forwards, or a posterior, which we're seeing in the boxing match here. Not a good thing. Shoulder. Now, you can see all these words and it looks frightening, but remember those basic words. Acromion, the top bone of the scapula. Alphabetically, A comes before C, so coracoid's below it. And there's a glenoid fossa that's covered right now with ligaments. And the humerus. So you just remember those 3 parts and look at this. Coracohumeral. Well, coracohumeral. So it's the coracoid process here and the humerus. So there's your attachment right there. It's a sheet of ligament that's going to strengthen the anterior or the front of the shoulder. The glenohumeral, which is here. Oh, wait. No. Glenohumeral is going to be huge. Here's a glenohumeral down here. Yeah. If you lower right, you see the massive ligament that helps form the joint capsule. It's going to do a lot of stabilizing and prevent excessive ROM. Transverse humeral. It's just like a little band-aid coming across the upper diagram. It's going to pin that tendon sheath, and the sheath allows the tendon of the biceps brachii to slide back and forth. Glenoid labrum is going to be underneath, and it's just around the rim. It's like a gasket around the glenoid fossa there. Bursa, you can see these green structures, are for absorbing shock, and they reduce friction as well. If we have a torn labrum, which you'll see right here, that happens to all of us, and as we age. But the more we abuse that joint, the faster it's going to wear out. It's kind of a catching pain. Just certain postures are going to cause this sudden. It's like a catch, just like the word suggests. The shoulder is the most dislocated part of the body, and that's because, okay, we have this great range of motion, ROM, but we pay a price because it's not very stable. Partial dislocation, a subluxation, means the head of the humerus is partially out, and I don't have a good example of that. Just imagine this femoral head just slipping off anteriorly, just forward, just a little bit. It'll pop back in, but a lot of blood vessels are torn in that process, a lot of trauma. So even though it's a short, it may last less than a second dislocation, it still may take months to heal. Separated shoulder occurs in the acromioclavicular joint. So if you remember, there's the acromion upper right. It's part of the scapula. Scapula has an acromion and has a coracoid. Okay. So if there's a separation there, the acromial end of the scapula, that's often one of those contact sport injuries, a lot of trauma. Elbow, again, this one looks complicated, but it's a uniaxial hinge joint. Extension and flexion is all that's allowed. Major parts, let's look at the ulnar collateral ligament. Here it is to the right, and we're looking at the, let me see, this is medial. Yeah, okay. And it's going to restrict medial movement at that joint. So here it is. Sorry for the delay. I just want to make sure. Usually I write medial and lateral, and I should have here. So medial comes first here. Now we have the radial collateral, and here it is, lower diagram, radial collateral. And it's going to, as you might guess, limit excessive lateral movement. So these make sense. The annular ligament is going to circle where's the, I think we'll see it in the next, let's take a look at the next one, because we're going to continue with the elbow. Annular, there it is. See that coming across? Think of an annulus. Okay, hinge joint. The lateral epicondyle of the bone, if we have a lot of tension there, we get lateral epicondylitis, or just sometimes called tennis elbow. And look to the far right, you see there's a lateral epicondyle, important attachment site for several muscles, like it's probably the brachioradialis coming across there. Medial epicondylitis, pitcher's elbow, which is here, and this is due to the large bundles, transverse muscles, ligaments here that become inflamed. It's a certain action that pitchers make when their elbow snaps medially, just briefly. It puts a lot of tension on there. And finally, we have the nursemaid's elbow, dislocation of the radial head. Or, if you ever take a child, sometimes parents do this, they get excited and they swing the child around in the air in a circle, holding their arms. It's a lot of fun, but it can cause a dislocation of the radial head. It slides past the angular ligament, and we have problems there. Here you can see it right here. Just a little inflammation. Not a happy child there. Hip joint. It is a ball and socket, and you can't see it in this image here, but underneath all these ligaments, a nice head of the femur and acetabulum to receive that. The iliofemoral ligament, here it is in big bold letters, is a major force that's going to keep that hip, the head of the femur from being dislocated. It's one of the strongest ligaments in the body, and it's going to prevent hyperextension of the femur at the hip, and that's a good thing. Pubofemoral ligament, and here it is, close to the iliofemoral. And think of pubic, right? The pubic symphysis right here, the joining of the pelvis, the anterior fusion of it. Here we have a ligament that's going to extend from the rim of the acetabulum, and we cannot see that here because it's underneath. But and then to the neck of the femur. So here's the neck, kind of buried under the iliofemoral. You can see a little bit of the neck here on the lower right, the femur. The ischiofemoral, which we do see on the lower right, extends from the ischial wall border. So we think of the ischium of the pelvis, and goes to the neck of the femur right here. Right. A lot of pressure being applied to that neck. We're still continuing with the hip, and the acetabulum labrum is the fibrocartilage rim, and it's not showing up. You can barely see the words here. There it is. It kind of extends the socket, and it provides a little bit of stability to keep just one more thing to keep that from having a dislocation. The ligament of the head of the femur, which is, darn it, I cut it off. I cut it off because I wanted to enlarge the picture though. So here's the ligament of the head of the femur coming here, and it's going to attach to the fovea capitis, which we're not seeing here. Oh no, here's the fovea capitis right here. Sorry. Fovea capitis here. And there's some blood vessels and artery here. And that helps keep the tissues alive in this region. Right? Because this is avascular, right? Cartilage doesn't have its own blood supply, but sometimes there's arteries that'll pass between the fibers. Transverse ligament, take a look here. Now there's a little acetabular notch in the bone that we're not seeing because it's covered by the transverse acetabular ligament. Okay, and it's going to help support the labrum around here. So it's a marvelous structure. You know, I'm just going through this so fast when really it deserves it deserves a lot of respect. This fantastic joint. Okay, there are trochanteric bursae, and you see them in kind of purple. And these are like a synovial joint. They have a fluid much like synovial with nutrients, phagocytes, and so forth. And they're over the you can see. Let's see. Yeah, here's the greater trochanter. See, this trochanter is a big knobby structure. You can see the lesser here. A big knobby structure that could tear nerves or damage blood vessels. And so, in its wisdom, the body has these pads of bursae to reduce friction and you reduce wear on any kind of tissue, not just the muscles, but any tissues that come near that bony part of the hip. The bursae take care of. All right, I think we've hit our first 4. Look through these again. Again, the first time through, sometimes your head's spinning because it seems so confusing. But little by little, the names of the bones are the key, I think. All right, operator. Thanks for listening.